Okay, so we'll be discussing the basic lab findings. So actually, when speaking about the lab findings, we are actually discussing about only the blood parameters here. And of the blood parameters, we have got many blood investigations. Of that, we'll be only discussing the most basics and absolutely essential ones. Okay, so we'll be discussing mainly about CBC, that is complete blood count, renal function test, serum electrolytes, liver function test, ABG analysis. Then if time permits, we can discuss about calcium, uric acid, thyroid function test, magnesium, phosphorus and all. But I don't think we will be having that lot of time, but let's try to include the maximum. Okay, so speaking about the lab investigations, these are the basic lab investigations. But we have many advanced lab investigations, like we can do autoimmune encephalitis panel in blood. We can do, for example, we can do ANA profile in which there will be different antibodies. We can do genetic analysis. So there are actually many investigations, but we'll be discussing the basic ones here. So the first and important, most important point when we discuss about basic lab investigation is to take the decision that when do you need to do an investigation. Okay, that's the most important part. That means when you have to do an investigation, a majority of people don't know when they need to an investigation. They need to do an investigation. So for this purpose, that we'll be discussing throughout the session, that when we do an investigation, what all clinical symptoms are suggestive of which all investigations, that all we will discuss in the coming 1 hour. But there is something called the routine blood investigation. So once again, I'm telling we'll be discussing the ultra basics. Okay, we'll be starting from the basics and we'll be building it from there. So what are all the routine investigations? So whenever a patient comes to you in casualty, not always in OPD. In OPD, you always need not do investigations. But whenever a patient presents to you in casualty, to assess the condition of that patient or how the body metabolism of that patient occurs, we need to do certain basic investigation, and we collectively call them as the blood routines. Simply routines, or we call them as the blood routines. Okay, so which are the blood routine investigations? First one is CBC, otherwise called complete blood count. Second one is serum electrolytes. That is, there are many electrolytes, but what we focus maximum is on sodium and potassium. Okay, so we have electrolytes other than we have chloride, we have bicarbonate, we have calcium, we have magnesium, we have a lot of electrolytes other than this, but what we focus mostly is on sodium and potassium. And third one is RFT, that is renal function test. And renal function test comprises of two parameters. One is blood urea, and second is serum creatinine. Okay, so these two are the parameters which are included in the renal function test. Okay, now the fourth one, this is occasionally included in the routines. This is in some hospitals or in some colleges, this is part of routines, but not always. But the other three, that is CBC, electrolytes, and RFT, are always part of the blood routine investigations. And fourthly, sometimes we do LFT, and the components of LFT we'll be discussing in subsequent session. We have bilirubin, we have direct bilirubin, total bilirubin and direct bilirubin. We have liver enzymes, that is AST and ALT. We have albumin, we have globulin, we have INR, we have alkaline phosphatase, and LFT comprises of many investigations that we'll be discussing. But one important thing to remember here is that these are the basic investigations, that is CBC, serum electrolytes, renal function test, and liver function test. Okay, so let's start with the simple one, the most simple one, CBC. So CBC, as the name suggests, you know, all know the full form of CBC. CBC means it is complete blood count. CBC means complete blood count. Okay, so for CBC, I'll just show you a CBC first. So this is a CBC. This is actually a CBC from my hospital. So these all are the parameters included in CBC, and I'll just highlight here the most important ones. So in CBC, as the name suggests, that is called complete blood count. So it will include those the amount or the number of blood cells in our blood. Okay, so the most important parameters in CBC, one is hemoglobin. This is one of the most important parameters in CBC. The second one is total WBC count. And the third one is platelets. Rest are also important, but the most important, if somebody asks me which are the three most important parameters in CBC, I would say one is hemoglobin, one is total WBC count, and third one is platelet count. Okay, so let's leave the other parameters there itself. First, let's focus on these three parameters. Okay. So speaking about the normal value of hemoglobin, according to WHO, it is 12 to 16 in females and 13 to 17 in males. Okay, so this is the normal value of, this is gram per deciliter. Okay, this is in gram per deciliter. So this is the normal value of hemoglobin. It is 12 to 16 in females and 13 to 17 in males. So at about average, you can take that the normal hemoglobin value is from 12 to from 17, irrespective of the sex. But it is slightly lower in females and slightly more in males. So this is the normal value of hemoglobin. Now, coming on to WBC count. The normal value of WBC is from 4,000 to 11,000. This varies in different books. This value varies in different books, but the average value of or average number of WBC count is from 4,000 to 11,000. Okay, some books says it's from 4.5 to 11,000, some says from 4,000 to 10,000, but you can take the average value of WBC to be from 4,000 to 11,000. Now, the third parameter is platelet count. Third parameter is platelet count. And the normal value of platelet is from 1.5 lakhs to 4.5 lakhs. So, one important point here, usually 90% of the time, you all guys will be having the normal values in majority of the laboratories available in our state. Okay, or rather in our country, all the lab values or all the laboratories shows the normal value also. So it's not absolutely necessary for you guys to remember the normal value, but it will be helpful because in some certains or some institutions, especially in medical colleges, you don't get the normal values there. So you need to know the normal values. So these are the normal values. So for hemoglobin, it is 12 to 16 in females, 13 to 17 in males. For WBC count, it's 4,000 to 11,000. And for platelet count, it is 1.5 to 4.5 lakh. Okay. So this is about the normal value. So guys, we are almost 10 minutes from the starting of the session. Are you guys able to catch up? Just give me a quick feedback because I just really don't know because I'm just speaking in front of a camera. Are you guys able to catch up? Shall I continue? Just let me know and I'll continue. Okay. So everybody is fine. So let's continue. Now, speaking about anemia. So we have already spoken that the normal value of hemoglobin, the lower limit of normal is 12 in females and 13 in males. So that means a value of hemoglobin less than 12 in females or less than 13 in males is called anemia. So anemia is basically a decrease in either hemoglobin level or the RBC count or both. So regarding hemoglobin, a value of less than 12 in females or less than 13 in males is called anemia. Okay, that's about anemia. We'll be speaking about different types of anemia and at all how to interpret a CBC. I'll be coming to that point, but just know that. Now, what is leukopenia? As the name suggests, leuco means WBC or leuco means white and penia means a decrease. So leukopenia means decrease in WBC count in bloods. And what is leukocytosis? Leukocytosis is simply increase in WBC count. Okay, leukocytosis increase in WBC count, leukopenia is decrease in WBC count. I hope that's all pretty clear. Now, thrombocytopenia is decrease in platelet count and thrombocytosis is increase in platelet count. These are the basics. So we have to start from here. So I hope up to this point it's fine to everyone. So anemia is basically a decrease in hemoglobin or RBC count. Leukopenia is a decrease in WBC count. Leukocytosis is an increase in WBC count. Thrombocytopenia is a decreased platelet count and thrombocytosis is an increase in platelet count. Okay, now let's come on to the point. So let's come again to the CBC. So in the CBC, we don't know whether it's the actually CBC of a male or a female. Here the HB is 11.2. Here the HB is 11.2. Okay, so since HB is 11.2, we know that it's below 12. So whether if this person is either female or male, it's still anemia because it is less than 12. So irrespective of the sex, it is anemia. Okay, and here we have the normal value 13 to 17, which means this is the CBC of a male. Okay, so here this patient definitely has got anemia. Now, whenever I see anemia, or just let's speak about the other three and then we'll come back to anemia. Now, this patient's WBC count is 10.2. Is that normal? Is that normal? According to this labs count, this is actually the CBC report of my hospital. Here the normal is 4,000 to 10,000. But I have told you that the normal count, standard normal count of WBC is from 4,000 to 11,000. Considering that 10.2 is also normal. Okay. Okay. If it had been 10,000, if 10,000 was normal, this patient has got leukocytosis. But usually what we consider normal is from 4,000 to 11,000, which means this is normal. Now, coming on to platelet count. Here the platelet count is 70,000. Here the platelet count is 70,000. So, when the platelet count is 70,000, we know that the normal value of platelet is, we already discussed, it is between 1.5 lakh to 4.5 lakh. So, here we are getting only 70,000, which means this patient has also got thrombocytopenia. So, this patient has got anemia and this patient has also got thrombocytopenia. Is that clear? Okay, now just let me tell you one thing here itself. We have actually got three bloodlines. We have got RBCs, we have got WBCs, and we have got platelets. Whenever two of these bloodlines, whenever the counts in two of these bloodlines decrease, we call it the bicytopenia. We call it as bicytopenia. Bi means two, cyto means cell, penia means decrease, which means there's a decrease in two cell lines. That is called bicytopenia. So if a patient has got anemia and thrombocytopenia, we can call it bicytopenia. If a patient has got anemia and leukopenia, we can call it bicytopenia. If a patient has got leukopenia and thrombocytopenia, we can still call it bicytopenia. Any two combinations of a decrease in cell count, we call it as bicytopenia. I hope it's clear up to this point. Okay, now whenever I see anemia in a patient, I need to have a lot of differentials into mind. Okay, whenever I see anemia in a patient, a lot of differentials should come into my mind. Okay, so what are all those differentials? So let's go to the basics. Let's go to the first year physiology, what we have learned in physiology. So why I'll be just discussing, I will not be discussing the entire anemia here. I'll just be discussing how to differentiate between different types of anemia. So whenever you see anemia in a patient, we know, I'm not writing it, we know that a patient can have anemia if there is decreased production of hemoglobin or RBCs. That's the first subgroup. Secondly, a patient can have anemia if there is increased destruction of RBCs or hemoglobin. These are the main two conditions when the patient can get anemia. Either there is a decreased production or there is a increased destruction. Okay, so decreased production, we can have decreased production. Firstly, if the patient has got iron deficiency, this is the most common thing. If the patient has got iron, as you all guys know, iron is essential for the function of hemoglobin. So if there is an iron deficiency, patient will be having anemia. Patient will be having decreased production of hemoglobin. Anemia.
Well done, boss.
Okay, is it clear? So that's the first condition. Second one is vitamin B12 deficiency. Other than this, also we have a lot of causes of anemia, but these are the most two common which you come across during clinical life. First one is iron deficiency, and second one is vitamin B12 deficiency. Okay, so these two are the two main causes of decreased production. Now, the patient can have anemia due to increased destruction. With increased destruction of RBCs, we call this as hemolysis. Hemo means RBC, lysis means destruction, and hemolysis means destruction of RBCs. So, we get hemolysis or increased destruction first in conditions like hemolytic anemias. Like we have many types of hemolytic anemias, we have sickle cell anemia, we have many types of hemolytic anemias. So in hemolytic anemias, we get hemolysis or increased destruction of RBCs. Second one is in splenomegaly. We know that spleen is the graveyard of RBC. So in spleen, there is destruction of RBC. So whenever there is splenomegaly, the size of spleen increases, the activity of spleen increases, more RBCs are trapped in spleen and more RBCs get destroyed. So in splenomegaly also, we get increased destruction of RBC and patient will be having anemia. Okay, so these are the main, all types of anemia we have left. We have many types of anemia. We have anemia of chronic disease, we have sideroblastic anemia, we have dimorphic anemia, we have many types of anemia. But as a basic level, these are the important anemias we should look when we see a decreased hemoglobin count. So whenever we see such a pattern or whenever we see anemia, what all further workup we should do? What all further workup we should do? So the first one is, whenever we see anemia, we are firstly suspecting iron deficiency. So since we are suspecting iron deficiency, we need to do serum iron, serum ferritin, TIBC, and TSAT. TSAT means transfer in saturation, and together all these are called iron studies. So whenever we see anemia, we need to do iron studies, and iron studies include iron, serum ferritin, TIBC. TIB means total iron binding capacity, and T saturation, that is transfer in saturation. So to rule out a iron deficiency anemia, we need this much investigations. Now we need to rule out a vitamin B12 deficiency also. So we also look for vitamin B12 levels. So in this side we have written the causes of anemia, and in this side we are writing the workup of anemia. That means whenever we see anemia, what all further workup we'll do. So we'll do iron studies, we'll do vitamin B12 level. Now, whenever we suspect, so these are the main two investigations. Now, other than that, whenever we see anemia or whenever we suspect hemolysis, the important thing to do is an LFT, because you know that hemoglobin consists of heme and globin, and destruction of this causes production of bilirubin. We know that bilirubin is a end product of hemoglobin metabolism. So since there will be increased hemolysis, there will be increased bilirubin production, and that to the unconjugated or indirect part. So that whenever there is increased hemolysis, patient will be having unconjugated hyperbilirubinemia or indirect hyperbilirubinemia. So to rule out hemolysis, one of the important investigation to do is LFT. Never forget this. Okay, it's a basic investigation, but many people misses that. Okay, and other than that, what we can do? We can do a retic percentage or reticulocyte. What I mean by retic percentage is reticulocyte percentage. So whenever a patient will be having increased destruction, the bone marrow tries to produce more and more RBCs. And whenever more and more RBCs are tried to produce, we know that reticulocyte is a precursor of RBC. So whenever there is a more production of RBCs, there will be more production of reticulocytes, and there will be an increase in reticulocyte percentage. Normally, we get only up to 0.5 to 1% of RBCs are reticulocytes. In hemolysis, we'll get more than 1% or more than 2% of reticulocytes. So that's an indicator of hemolysis. Now, the next important thing is LDH, that is lactate dehydrogenase. LDH is an enzyme which is seen mainly in RBCs and other cells. So whenever there is an increased destruction of cells, including increased destruction of RBCs, LDH is released into blood, and we get an increased level of LDH in hemolysis.
Hello.
Okay. Now, the next important thing we need to look is and this is the most important thing, peripheral smear, because whenever you see anemia, we need to differentiate what type of cells are those, whether it is microcytic hypochromic anemia, whether it is normocytic normochromic anemia, whether it's megaloblastic anemia, to differentiate, or whether the peripheral smear contains any abnormal cells. For example, we'll be having cells like target cells, we can get cells like pencil cells, we can get cells like Cabot rings, we can get many different findings in different types of anemias. So to find out the morphology of different cells in the blood, we need to do peripheral smear. So we have written the causes of anemia. We have also written the workup of anemia. So these all are the, other than that, we can do a Coombs test. We can do a direct Coombs test if we are suspecting immune hemolytic anemia, AIHA, what we call as the AIHA, autoimmune hemolytic anemia. So whenever we are suspecting immune hemolytic anemia, we can do direct Coombs test also, but that's not that important. That's important, but at this point of time, we need to know whenever we see anemia. Other than this, we can also look for an USG abdomen. I'll write USG abdomen also here. Okay, why USG abdomen? Because of two reasons. One is because we are suspecting a splenomegaly. If there is splenomegaly, there is increased destruction of RBCs, and increased destruction of RBCs, we can identify splenomegaly through ultrasound of abdomen. Okay, and the second one is in conditions like malignancies, especially hematological malignancies or lymphomas, there will be hepatosplenomegaly. And in malignancies, you know that the WBC, for example, in myeloid leukemias, acute myeloid leukemia or chronic myeloid leukemia, WBC count is increased at the cost of RBC and platelets. So WBC count will be more, RBC and platelet count will be less. Okay, so these are the investigations we do when we see a patient with anemia. I hope it's fine. Okay, now let's move on. Whenever we see leukopenia, leukopenia is actually not that important for you guys, but just know that leukopenia and leukocytosis, we have two terms. One is leukopenia and leukocytosis. Usually, leukopenia we see in viral infections. We can see in many conditions, but we clinically come across usually is viral infections. Certain infections like dengue, influenza. Okay, in all those infections there will be. So when we look CBC in a suspect, where patients come to you with complaints of fever and cough, we are suspecting a upper respiratory tract infection there. We do a complete blood count. If we find the WBC count to be on the lower side, we suspect a viral illness like influenza. And if we suspect a and if we see WBC count to be high, if we see WBC there is a leukocytosis, we suspect a cause due to secondary to bacteria. Okay, so in bacterial infection there will be leukocytosis. So in bacterial infection there will be leukocytosis, and in second to that, next to that, it is very 90% of time whenever you see bacterial infection, it is due to whenever you see leukocytosis, it is due to bacterial infection. But sometime there are other causes of leukocytosis also. For example, if the patient is using steroids, if a patient is using steroids for a long time, he may get leukocytosis. But that's not that important. What is important clinically is one is hematological malignancies. For example, what we have already mentioned, that is AML, CML. In conditions like that, we can get very increased count of WBCs. So leukocytosis can be seen in bacterial infection and in hematological malignancies. Leukopenia usually seen in viral infections like influenza. If the patient is having infections like pneumococci, the count will go up. That is, it will go more than 11,000. And if the patient is having conditions like CML, it can go up to lakhs. Total count may come up to lakhs. So to differentiate any kind of morphology in complete blood count, if we find any abnormality in some complete blood count, the next step is always a peripheral smear. That's important, guys. Whenever we find any abnormality in a complete blood count, the next step is peripheral smear. Is that clear? Okay, I hope it's fine. Now, let's come to the third point, thrombocytopenia. Let's come to the third point, that is thrombocytopenia. So thrombocytopenia, as the name suggests, it is a decrease in platelet count. So whenever I see a patient with a platelet count of less than 1.5 lakh, whenever I see a patient with a platelet count of less than 1.5 lakh, what I suspect is, first thing, if the patient's previous platelet counts were normal, okay, if the patient's previous platelet count was normal, and the presently his platelet less than 1.5 lakh. Okay, his previous platelet count was normal, and presently his platelet count is less than 1.5 lakh. What we suspect is a viral infection, like we suspect a viral infection, usually which is dengue. Okay, this is the most common viral infection which presents with severe thrombocytopenia. The thrombocytopenia can go up to below 10,000 or 20,000. Okay, it is usually between 50,000 to 1 lakh, but the platelet count can go up to 3,000, 2,000. All I have seen with patients with dengue, I have seen platelet counts of 1,000, 2,000 and all. Usually it's between 50,000 to 1 lakh, but it is severe if the patient's platelet count falls below 20,000 or 10,000. Okay, so infections like dengue can cause thrombocytopenia. Now, just an important point here, that is thrombocytopenia plus leukopenia. So there is thrombocytopenia and there is leukopenia. So I have told you that leukopenia occurs in viral infection. So thrombocytopenia also occur in viral infection. So thrombocytopenia plus leukopenia is usually seen in dengue infection. Okay, so this we can call as bicytopenia because there is a decrease in more than 2 cell lines. So bicytopenia, including thrombocytopenia and leukopenia, is usually seen in infections like dengue. Okay, now if I have thrombocytopenia plus leukocytosis, I have told you leukocytosis occurs with bacterial infections. So thrombocytopenia plus leukocytosis is classically seen in leptospirosis. This is important. So whenever I am suspecting an infection and I see a thrombocytopenia, I'll immediately look onto the WBC count. So if the patient has thrombocytopenia plus leukopenia, it is usually seen in dengue infection. And if the patient has thrombocytopenia plus leukocytosis, it is usually seen in leptospirosis. I hope it's clear. So whenever I see thrombocytopenia in a patient, I'll first suspect a viral infection like dengue. Is that clear? Okay. Now, second most important cause that causes a thrombocytopenia is a chronic liver disease. Okay, so patients with chronic liver disease can have thrombocytopenia. Why? Because CLD causes splenomegaly, and similar to RBCs, platelets are also destroyed by spleen. So splenomegaly causes thrombocytopenia. That's why patients with CLD have a decrease in platelet count. Okay, now third, I can see thrombocytopenia in conditions like ITP. I can see thrombocytopenia in patients like ITP. ITP means, you know, it is called idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura. Here there will be a decrease in platelet count without a particular reason. Actually, it has got reasons. It's a little complicated, but we call it ITP. Now, the fourth condition is autoimmune diseases. Autoimmune diseases like SLE in patients like with autoimmune diseases like SLE can cause thrombocytopenia. So why am I discussing it like this? Because whenever you see thrombocytopenia in a patient, these are the four, not four. Now the fifth one is again hematological malignancy. I have told you in hematological malignancy, there is increase in WBC count at the cost of RBC and platelet count. In hematological malignancy, there is an increase in WBC count at the cost of RBC and platelet count. So WBC count goes up, RBC and platelet comes down. Is that clear? Okay. Now, so other than this, we can have many other conditions like we have DIC, we have MAHA. DIC means disseminated intravascular coagulation. MAHA means microangiopathic hemolytic anemia. All these conditions we can have thrombocytopenia, but the most important 5 conditions I have written here. So this is about CBC, guys. So whenever I see CBC, so we have discussed about the normal count. We have discussed about the different patterns in CBC, that whenever you see anemia, what all you need to suspect, and when you see anemia, what all further workup you should do. Now, when you see leukopenia, what you should suspect. When you see leukocytosis, what all things you should consider. These are the 2 important things that you should consider. And whenever you see thrombocytopenia, these are the 5 important things. 6th one is also important, but it is relatively less common. Not less common, but usually what should come into your mind is these 5 causes. So this is basically about CBC. So is that clear? So just give me a quick bit feedback. We have passed 30 minutes and I have completed CBC. Now the rest of the investigations we can complete it more faster. CBC was the most important one, so that's why I have detailed here. Is that clear to everyone? Shall I continue? Okay, everybody saying is that it is clear. So let's continue. Okay. Okay, so let's continue. So we have discussed about CBC. So I'm not going to the further details because we have got many more things. We have MCV, we have RDW. All of that has got importance. We have absolute neutrophil count, we have absolute eosinophil count. All of those have got importance. But at a basic level, what we need to know, we have already discussed. If I go to for more details, the session will become very lengthier. So I just want to limit it into at least a session of 1 hour 15 minutes. That's why we need to just skip this for the time being, but we have discussed the most important things. So when you get a CBC, the 3 most important I'm going to look is, one is hemoglobin, one is total WBC, one is platelets. Whenever I see a fall in platelet, what all we should see, that I've discussed. Whenever I see a fall or rise in WBC, what all we should look, that I have discussed. And whenever we have a fall in platelet, we can also have increase in platelet, that we have not discussed. Let's leave that aside now. But whenever we have a decrease in platelet, which we usually see more commonly, especially in this patient. In this patient is having anemia and thrombocytopenia. This patient actually has got ITP. Okay, this is actually a CBC of a patient with ITP. Okay, so this patient has ITP. So whenever we see platelet count decrease or platelet count increase, or whenever we see WBC and RBC count variation, what all we need to discuss. So anemia plus thrombocytopenia combination, it is seen in many conditions, but let's first finish the rest of the investigations, and then if we have time, we can come back to this because it's not that important. And workup we have already discussed. We have already discussed the workup of anemia. Okay, we have already discussed the workup of anemia. So these are the investigations which we do for the workup of anemia. I hope it's clear. Okay, Now, let's move on to the next important one, that is called RFT. RFT, or it's the renal function test. So at this point of time, we are discussing only and only about the routines. So routines include CBC, routines include RFT, routines include electrolytes, and in some patients, routines include LFT. So that's what we'll be discussing. So speaking about RFT. So RFT, as you know, it is renal function test, and we have two important things in renal function test. One is creatinine, second one is urea. So the normal creatinine, it actually varies with age, but we can use this reference. Normal creatinine is 0.7 to 1.4. Some books say it's 0.7 to 1.3, some say it's 0.7 to 1.35, but usually average we can take the normal creatinine to be between 0.7 to 1.4. And the normal urine output in an adult person is 1 ml per kg per hour. 1 ml per kg. This I am not mentioning all the values, but some values you need to learn, because this will be used by you, or this will be important to read certain investigations or elicit certain findings. For that, certain values are important. So normal urine output is 1 ml per kg per hour. Normal creatinine is 0.7 to 1.4. And isolated elevation of urea, let's leave that aside now. I'll come back to that if time permits. But before that, let's see a normal renal function test. So this is a normal renal function test, again from my hospital. This is the value of urea. This is the value of creatinine. Here urea is 17.5. Urea is 17.5. Usually the value of urea ranges between 15 to 45. That's the normal value of urea. Okay. Normal value of urea is between 15 to 45. Okay. So that's the normal value of urea, and the normal value of creatinine, as we have already mentioned, it's between 0.7 to 1.4. Here the creatinine is 0.86. So fairly, here it's a normal RFT. It's a normal renal function test. Here the urea is also normal. Here the creatinine is also normal. So this is a normal RFT. Is that clear up to this point? Isolated elevation of urea, I will come back to that later. But before that, just know when this will be abnormal. So in certain scenarios, one thing to stress here is that usually we take clinical judgments based on the levels of creatinine. Okay, because creatinine is a much better indicator than urea to assess because creatinine is an indirect indication of glomerular filtration rate. So the value of creatinine clearance is actually equal to glomerular filtration rate. That's why we are measuring creatinine. I'm not going to the details of that, but the value of creatinine indirectly measures you the value of GFR. That means how well our kidneys are filtering or how well our kidneys are functioning. Okay, so urea, usually we have got significance for urea. We have got actually extreme significance for urea, but at our point of level, what we focus more on is in creatinine, because creatinine is a better indicator. I hope it's clear. Okay, so whenever that patient has got an elevated creatinine, that is called acute kidney injury. If the previous creatinine level of the patient was normal, okay, if the previous creatinine of the patient was normal, we call it as acute kidney injury, or it is a gradual increase of creatinine in some patients. For example, in patients with diabetes, the diabetics is going to affect kidney in the form of diabetic nephropathy, or we call it as the diabetic kidney disease. So in such conditions, there will be gradual increase in creatinine, which we call as chronic kidney disease. These are all of the basics. I hope you all know this. Okay, so when there is an acute elevation of creatinine, we call it as acute kidney injury. And when there is a gradual increase of creatinine, we call it as chronic kidney disease. So suppose if in one patient, I am going to see a creatinine value of 1.7. So I definitely know that 1.7 is more than 1.4. So I know that this creatinine value is abnormal. So whenever I see that, I know this creatinine value is abnormal. So whenever I see such an abnormal creatinine value, do you guys know what the next immediate question or what the next immediate thing I'm going to look onto? Can you just please comment it down? In a patient presenting to me in casualty, I have never seen the patient before, but when I do the routines, I'm seeing that the creatinine level of the patient is 1.7, and I know that 1.7 is abnormal. So whenever I see a abnormal value of creatinine, what is the next step that I'm going to look? Can anybody come mention it in the comment box? In clinical situations, what's the next immediate thing we are going to look onto? Exactly, I mean, Basil. Exactly, we are going to look onto the previous value. Okay, so we are going to check excellent. We are going to check the previous value of creatinine. We are going to check the previous value of creatinine. So if the previous value of creatinine is also high, so there are two possibilities. the previous value of creatinine is also high, or the previous value of creatinine is normal. So if the previous value of creatinine is normal, it is likely to be AK. I'm not saying it's always AK, but it is likely to be AKI. And if the previous value of creatinine is also high, we can call it as CKD, because the patient has already got elevated value of creatinine. It is chronic kidney disease. It is not acute kidney injury. If the previous value, we can differentiate acute kidney injury and chronic kidney disease in different methods. Okay, we can actually differentiate it in different methods. But for the time being, what we are looking is, we look onto the previous value, and if the previous value is also high, it is chronic kidney disease. If the previous value is normal, it is likely to be AKI. And here I have just included a table which shows the definition of AKI. Okay, this is a table from Harrison, and this shows the definition of AKI. Here, let's ignore the stage 2 and 3, because if we know that it is stage 1, at least it is stage 1, we can classify it as AK, and can say that this patient needs further investigations or further management. So just let's know what is AKI. So we call the it is an AKI or stage 1 AKI if there is, first one is, if there is more than 0.3 milligram per deciliter increase. Okay, so from the previous value, if there is a 0.3 milligram per deciliter increase in creatinine, we call it as AKI. So AKI usually occurs within days to weeks. Okay, it usually occurs within days to weeks. So from the previous value, if there is more than 0.3 milligram per deciliter rise of creatinine, we call it as AKI. Or in other words, we can also call, if the previous creatinine level, we have got more than 1.5 to 1.9 times from the baseline. You need to learn either of the two. I usually goes with this 0.3 milligram per deciliter, because if the patient has got usually more than 0.3 milligram per deciliter, it is naturally more than 1.5 to 1.9. So what I remember is more than 0.3 milligram per deciliter increase in creatinine. Or in terms of urine output, at the beginning of the renal function test, I have told you guys that the normal urine output is between 1 ml per kilogram per hour. It is 1 ml per kilogram per hour. So a decrease in urine output less than 0.5 ml per kilogram per hour for 6 to 12 hours, at least 6 to 12 hours, we can call it a stage 1 AKI. So acute kidney injury is defined based on two criteria. Okay, it is based on the value of serum creatinine. Second one, it is based on the urine output levels. Okay, so if there is an increase of creatinine more than 0.3 milligram per deciliter, we can call it as AKI. Or if it is more than 1.5 to 1.9, or if the urine output is less than 0.5 milliliter per kilogram per hour for more than 6 to 12 hours. So from this table, if you ask me what is the only one thing, it may sound messy because we have got 3 to 4 values here. But if you ask which is this one single thing you should learn from this table, it is this one. That is a rise of more than 0.3 milligram per deciliter creatinine over days to weeks. We can call it as AKI, and this patient will be needing further investigation. So that's how we differentiate AKI and CKD. Usually it's not like this. We have different parameters. We have actually got 3 parameters to differentiate AKI and CKD clinically itself. But for the time being, this is important. So whenever I see an elevated creatinine, I am going to look at the previous value of creatinine. And from that, if the baseline value, we call that the baseline creatinine. For example, actually in CKD, we have got 5 stages, which is actually based on creatinine clearance. So for some CKD patients, their baseline creatinine will be 2. That means for a long period of time, their baseline creatinine is 2. Okay, so their baseline creatinine is 2. So if we now, when we test the blood, when we see a creatinine of 2.1, or when we see find a creatinine of 1.9, that has not got much significance because their baseline is 2. But a patient with normal creatinine, if I am seeing a creatinine of 1.9, that is acute kidney injury. Okay, now there is something called AKI on CKD that we'll not discuss now, but at the basic level, at the grassroots level, what we need to know about renal function test, we have already discussed here. So we have discussed about the normal creatinine value. We have discussed about the normal urine output. This we can leave for the time being because it's not that important. Now we have discussed a normal renal function test, and we have discussed whenever I see an elevated creatinine value, what am I going to look? I am going to look the previous creatinine value. And based on that, I can call it either an AKI or a CKD. And when will I call it an AKI? If I got more than 0.3 milligram per deciliter increase in creatinine in over days to weeks. Now let's come on to the one of the most important topic, that is serum electrolytes. From SC, what we means is serum electrolytes. And serum electrolytes, I have told you there are many electrolytes, but usually what we focus is on, one is sodium and second one is potassium. Okay, now speaking about the normal values. Normal value of sodium. Normal value of sodium, according to Harrison, it is 135 to 145 milliequivalent. Okay, and normal value of potassium in according to Harrison, it is 3.5 to 5. Some says it's 3.5 to 5.5. It varies with different labs. But what Harrison say, Harrison is the standard book of medicine. So what Harrison says, that is normal value of sodium is between 135 to 145, and the normal value of potassium is between 3.5 to 5. So naturally, a sodium less than 135 is called hyponatremia. A sodium more than 145 is called hypernatremia. A potassium less than 3.5 is called hypokalemia, and a potassium more than 5 is called hyperkalemia. I hope it's clear up to this point. Okay, so that's about sodium and potassium normal values. So whenever I see a patient with the one of the four, that is hypo bar hypernatremia or hypo bar hyperkalemia. Whenever I see a patient with a we call that a dyselectrolytemia. We call that as a dyselectrolytemia. That means this means imbalance. Electro means electrolytes and lytemia means in bloods. So dyselectrolytemia, we call it a dyselectrolytemia when the patient has got an abnormal sodium or potassium value. So whenever I see an abnormal sodium and potassium value, the important thing I'm going to look is I'm going to review the drug of the patient. That means which all drugs the patient is into, because the most common thing to cause hyperkalemia or hyponatremia is the drugs they are taking. For example, if the patient is using diuretics, maybe loop diuretics, maybe thiazide diuretics, patient is maybe using maybe loop diuretics for cardiac disease or for renal disease. Thiazide diuretics, if the patient has hypertension, thiazide diuretics is one of the treatment of choice for hypertension. So if the patient is taking diuretics, it is natural that patient for that patient to develop hyponatremia, because the patient is going to lose sodium through urine. Patient may have hypokalemia also. So the patient who are taking diuretics, they can have hyponatremia or hypokalemia. Okay, now if the patient is taking potassium sparing diuretic, that means diuretic like spironolactone, eplerenone, triamterene, amloride, drugs like that. Usually what we see usually is spironolactone. Spironolactone is the most commonly used potassium sparing diuretic. So it's natural for that patient to have hyperkalemia. Clear? Now drugs like ARBs or ACE inhibitors, they all can cause hyperkalemia. But most important one is potassium sparing diuretics. So my point is, whenever I see a patient with a low or high sodium and potassium, the next thing I am going to review is their drugs, because there will be some culprit in the drug which is causing this dyselectrolytemia. Is that clear? Okay. Now we have 45 minutes into the session. Can I just get a feedback once again? Because I just wanted to ensure that you guys all are there and you guys are able to catch up. Is it clear up till now? Shall I continue? Okay, sure. Now, let's continue. So that's about the electrolytes value. So whenever I see an abnormal electrolyte value, the next thing I'm going to do is a drug review. Okay. Now, the further workup. So now let's speak about the two more. I have many important things, but the most three, hypernatremia we usually see, but what we commonly see, most commonly see is hyponatremia. And we can also see hypokalemia and hyperkalemia. So just quickly speak about the most important points in hyponatremia, hypokalemia, and hyperkalemia. So hyponatremia, hyponatremia is a serum sodium of which is less than 135. A serum sodium which is less than 135. That is what we call hyponatremia. So when we see hyponatremia, actually we have to do many investigations because we need to find the cause of hyponatremia. So actually the workup of hyponatremia includes urine sodium, serum osmolality, urine osmolality, etc. But even if you don't do that, you just find out the patient has got hyponatremia. We need to treat that hyponatremia. And the important thing while treatment of hyponatremia is you have been studying for a long time. That means acute hyponatremia. This you all guys know. Acute hyponatremia can be rapidly treated. And chronic hyponatremia, you should only correct gradually. So chronic hyponatremia, you should only correct gradually. This is because, as we all know, we suspect or we fear the most dreadful complication, that is osmotic demyelination syndrome. ODS means osmotic demyelination, also call it as spondyne myelinolysis, rapid correction of sodium. Recently, about 3 to 4 days back, I've seen one case of osmotic demyelination syndrome. It was not actually pontine myelinosis, it was extra pontine myelinosis. Mechanism is same, due to rapid correction of sodium, but it was not actually pontine myelinolysis, it was extra pontine myelinolysis. And what my consultant told was that it was actually due to the rapid correction of sodium itself. What my consultant, this is actually a dreadful complication. What my consultant told was that once you see osmotic demyelination syndrome, you are never ever going to correct sodium rapidly. Okay, because it's so dreadful. Okay, so he told me like that once you see, actually, I was not the one who corrected it rapidly, but we saw it as a consultation. And when we saw it as a consultation, he told me, like, just for a learning purpose, that when once you have seen a case of osmotic demyelination syndrome, you are never going to correct hyponatremia rapidly. So naturally, a doubt arises in my mind or our mind, that it means how much sodium we can correct in hyponatremia, whether it be acute hyponatremia or chronic hyponatremia. The maximum sodium level we can correct is 6 to 8 milliequivalent per day. This is important, guys. This is the maximum allowed sodium level that you can increase in a day. It should be less than 6 to, or it should be 6 to 8 milliequivalent per day. If it goes more than 8 to 10 milliequivalent per day, there is risk of osmotic demyelination syndrome. If the value goes more than 8 to 10 milliequivalent per day, there is definitely a risk of osmotic demyelination syndrome. So whenever you correct hyponatremia, this should be in your mind. My target is to correct only 6 to 8 milliequivalent per day. What if it happens? What if you increase by 12 in one day? You should adjust it in the subsequent day. That means if you correct 10 milliequivalents in the if you correct 10 milliequivalents in the first day, the next day you should correct only up to maximum to 5 or 6. That means your total in 2 days should be around 16. Okay, so if you happen to correct more than what we expect only 6 to 8 milliequivalent per day. If you happen to correct more than that, you should compensate it in the next day. Okay, so how will we treat hyponatremia? We have many methods. Usually we give only normal saline, because we know that normal saline contains 0.9 percentage and sodium chloride. Sodium chloride means it's basically sodium, and sodium it's what we need. So what we usually give is only normal saline is 0.9 percentage. But in severe cases, if the patient has got acute symptomatic hyponatremia, if the patient has got acute symptomatic hyponatremia, we give them 3% NS. This also we have learned, you have learned. So 3% NS, we have got many preparations. We have got preparations of 50 ml, we have got preparations of 100 ml, we have got 250 ml. Usually what we give is either 50 ml or 100 ml preparation at a rate of 10 ml per hour. Or for safety purpose, let's take it 8 ml per hour, but we can usually give up to 10 ml per hour. So only in acute symptomatic hyponatremia, this word is important. Only in acute symptomatic hyponatremia, we will give 3% NS. We never, ever give 3% NS for a patient with chronic hyponatremia. Is that clear? We never, ever give 3% NF for a patient with chronic hyponatremia unless the patient is severely symptomatic due to hyponatremia. Is that clear? Okay, so that's about treatment of hyponatremia. And thirdly, we have one drug called tolvaptan. Tolvaptan is actually the drug of choice for SIAD. SIAD, I think at least somebody of you might have heard. SIAD means syndrome of inappropriate ADH secretion. So the drug is tolvaptan, which is usually sold under the brand name Natris. This is the brand name, and it is actually we are giving it 15 mg OD. Usually up to 3 days, 4 days, or 5 days. Okay. So these are the three usual available options for treatment of hyponatremia. There are more, but these three are the usual thing, and the most commonly used one is 90% of times we use is normal saline or 0.9% sodium chloride. I'm not repeating it because there's a limitation of time. We have got something more to discuss. So this is about hyponatremia. So we have discussed about the management of hyponatremia. The two most important points here is, one is the rate you can correct hyponatremia. It's just around only up to 6 to 8 milliequivalent per day. And the second one is what all methods you can use. You can use NS. You can use 0.9%. That means NS means 0.9% sodium chloride. You can use 3% NS, or you can use tolvaptan. What we usually use is NS. Now, if I see a patient with hypokalemia, again, what I'm doing to do first I'll do drug review. Whenever I see a patient with hypokalemia, first thing I'm going to do is I will do the drug review. And if I could find one drug causing hypo or hyperkalemia, I'm going to stop that drug. If I couldn't find anything, patient may have hypokalemia and hyperkalemia due to many other reasons also. For example, a patient may have hypokalemia due to decreased potassium intake. Or else, if patient can have hypokalemia due to certain renal syndrome, you might have heard of syndromes like Bartter syndrome, Liddle syndrome, Littleman syndrome. All this causes hypokalemia. Now, the patient may get hyperkalemia due to certain other reasons. For example, the patient has got acute kidney injury. The potassium is not able to be excreted by the kidney. Patient's potassium goes up. So, always there need not be a drug which causes hypo and hyperkalemia, but quite often you see drugs causing hypokalemia and hyperkalemia. Okay. So whenever I see hypokalemia, I have got two treatment options. Usually if the potassium is less than 3, that means if the potassium is between 3 to not less than 3, if the potassium is between 3 to 3.5, we know that we call it hyponatremia when the potassium is less than 3.5. So if the potassium is usually 3 to 3.5, we are going to give them oral preparations, which is most probably sold under the brand Portchlor. So this Portchlor, it's actually a syrup. Syrup Portchlor we can give 15 ml BED bar TID. So usually if the potassium level is between 3 to 3.5, we give Portchlor. This is the most common thing you use. And if the potassium is less than 3, we go for IV potassium administration. That is, we give KCl. KCl can be given as either 20 MEQ or 40 MEQ or 60 MEQ or even more. Okay, this we will dilute in 500 ml NS and we give it over 4 to 6 hours. So this is the management of hypokalemia. Actually, I just wanted to discuss about the basic lab investigations, but together with that, let's discuss about the management also, because this is what you guys are going to face when you start practicing. Okay, this is the most common things which you guys are going to practice. So whenever I see hypokalemia, I will either treat it with oral preparations or I'll go for IV preparations. Oral preparations, I've got syrup Portchlor, which I usually give 15 ml BD or TID, or we can give IV KCl preparation, IVC potassium chloride preparation. And for this, if we are going for about 60 MEQ, we need a central line. Okay, we don't usually give 60 MEQ that high dose through peripheral line. If we are going to give up to 60 MEQ, we give through central line. So we can give potassium from 20 MEQ to 40 MEQ or 60 MEQ in 500 ml NS, which is given over 4 to 6 hours. That's the treatment of hypokalemia. And now let's talk about hyperkalemia. Actually, my handwriting is a little messy. I know that, but I can't help it, guys. This is my handwriting. So that's why I'm dictating. That's why I'm keep on dictating. I hope it's clear to everyone. Okay, now whenever I see hyperkalemia, so as by definition, hyperkalemia according to Harrison is more than 5, but in many labs it is more than 5.5. So whenever I see hyperkalemia, I'm again going to review the drugs. If there is no drugs causing the hyperkalemia, I'm going to manage hyperkalemia. There is actually 4 or 5 management modalities for hyperkalemia, but I don't think, just I'll mention now, we can give one is calcium gluconate. Calcium gluconate actually does not decrease potassium level, but hyperkalemia can cause severe arrhythmia because it destabilizes the myocardium. So why we give calcium gluconate? It is due to stabilize the myocardium. Dose and all I'm not going to discuss now because it's actually a session of basic lab investigations. If you guys need that, we can discuss it in another session. Okay. So this is about calcium gluconate. Another thing I can give is D25 plus insulin, because you know that insulin causes potassium to go inside cell. Insulin causes potassium to go inside the cell. So the potassium level in blood will decrease. But what happens when we give insulin alone? Patient will develop hypoglycemia. That's why we combine dextrose plus insulin. D25 means 25% dextrose plus insulin. Okay. Now the another option is I can nebulize patient with salbutamol. As you know, salbutamol is a beta-2 agonist, and since it's a beta-2 agonist, it causes the potassium to go inside the cell. Now I can give certain potassium binding resins, like Patiromer, which is usually sold under the brand name K-bind sachet. Okay, now I can also give sodium bicarbonate. Sodium bicarbonate also decreases potassium. Mechanism we don't have time to explain, but whenever we see hyperkalemia, these all are our treatment options. Okay, so we have got many treatment options for hyperkalemia. We can give injection calcium gluconate 10 ml 10% or 10 minutes for to stabilize the myocardium. We can give D25 100 ml with 10 unit insulin because insulin causes potassium to go inside the cell. But since the patient has a risk to develop hypoglycemia, we combine it with D25. We can give nebulization with salbutamol, which activates the beta 2 receptors and causes the potassium to go inside the cell. We can give certain potassium binding resins, which is called patiromer. Example, patiromer. And we can give bicarbonate because bicarbonate causes alkalosis and alkalosis in turn causes hypokalemia. So these are the options for treatment of hyperkalemia and hypokalemia. So we have discussed about hyponatremia. We have discussed, it's actually a little messy, but I hope it's clear to you. So we have discussed about hyponatremia. We have discussed about hypokalemia. We have also discussed of hyperkalemia. Naturally, you will be having doubt why I left hypernatremia. Because hypernatremia is not as important as these three. You see, hypernatremia can also cause seizure, guys. Hypernatremia is also equally important and it's also equally severe disease. But hypernatremia usually we don't see as commonly as we see these three. That's why I have restricted hypernatremia. We can discuss it in the subsequent session. For the time being, this is about serum electrolytes. So we have completed about serum electrolytes. So this is just a normal value of serum electrolytes. Here, the sodium, it's again investigation from a hospital. Sodium is 133. So it's that's on 135. The patient is having hyponatremia. And the hyponatremia between 130 to 135, it's mild hyponatremia. So this is a patient with mild hyponatremia. Potassium here is 4. Potassium, as we know, potassium normal value is between 3.5 to 5. So a value of 4 is between 3.5 to 5. And the potassium value here is normal. Now, we have already passed 9 o'clock, guys. We have, its time is already 9 p.m. and we have completed with the routines. So at the beginning of this session, I have told you about routines. Okay, so routines included CBC. We have extensively discussed about CBC. Routines include electrolytes, sodium and potassium. We have discussed about electrolytes also. We have already discussed about RFT also. But actually, I have got much more. I have got LFT. You can just see I got LFT. I have got ABG. I have got calcium, I got uric acid, I got thyroid function test, okay, and much more. Actually, for this 1 hour session itself, I was trying to plan to discuss. So I just wanted to know, should I speak about LFT also, or shall we wind up because it's already 1 hour? If you guys are interested, we can discuss about LFT. And ABG, I don't think we can discuss now because starting ABG, it's not much complicated, but it's a conceptual topic. So since it's a conceptual topic, we need to invest some time in that. So ABG we can discuss in a later session. But since you guys, if you guys are interested, we can continue with LFT. So everyone is asking to continue. So just finish with LFT also. Okay. So just finish with LFT. So LFT. So before going to LFT, let me just show you. LFT I'll be not detailing because LFT is actually, guys, what I have discussed till now. The most beautiful thing is LFT. Okay. CBC, sodium, potassium, and RFT, actually, we don't have much to sell. Actually, CBC, there is something to tell. CBC is interesting, definitely. But RFT and sodium, potassium, those are only 2 parameters. Okay, there is only urea, creatinine, sodium, and potassium. So, regarding the investigation, it's not that a beautiful investigation. But regarding management, there is much to speak. That's why I spoke about management there. But LFT is not like that. LFT is actually a beautiful investigation. So, detailing every little thing, it's not possible here. Let's try to finish LFT within 15 minutes, maximum 15 minutes. Let's try to finish it within 10 to 15 minutes. So, liver function test. So, this is a normal, actually, is it normal? It's pretty kind of normal. It's not completely normal. There is some abnormality. But let's speak. What are the parameters in LFT? So, in LFT, usually we have total bilirubin. The next one is direct bilirubin. Direct bilirubin, as you all guys know, direct bilirubin is also called conjugated bilirubin. Direct bilirubin is also called conjugated bilirubin. Okay. Now, since we have direct bilirubin, we have conjugated bilirubin, we have total bilirubin, and we have conjugated bilirubin. So it's natural, it's very easy to find out the indirect bilirubin. That's why they have not given the value of indirect bilirubin. Direct bilirubin minus total bilirubin minus direct bilirubin will give you the value of indirect bilirubin. That's why they have not mentioned. So total bilirubin, this minus this will give you indirect bilirubin, or which is also called unconjugated bilirubin. So these are the first 2 most important parameters in liver function test. Next one is the liver enzyme. So these 2 are bilirubin. Next, let's mark it in a different color. So these 2 are bilirubin. Next 2 is liver enzyme. Actually, third one is also kind of liver enzyme. But next one is, we have different names for that. We can call it either as AST or ALT. Okay, AST is aspartyl aminotransferase, ALT is alanine aminotransferase. AST is also called SGOT. ALT is also called SGPT. So in different labs or in your when you speak with your different teachers or professors, they are going to talk to you differently. Some will be using OT, means OT means SGOT. Some will be using AST instead of OT. Some may be using SGPT. Some may call SGPT as ALT. So these are used interchangeably. You need to know both. Okay. So AST, ALT. AST is also called SGOT. ALT is also called SGPT. I hope it's clear. That's about the liver enzymes. The significance I'll come on to. Okay, significance I'll come on to. First, let's familiarize with what all we look in LFT. Okay, so first let's familiarize with what all we see in LFT. Now, the next important one is alkaline phosphatase. The relevance of alkaline phosphatase, it's a marker of cholestasis. What does cholestasis means? Chole means something related to bile. Okay, chole means something related to bile. Stasis means stagnant. That means there is obstruction. Stagnation means obstruction. So there is obstruction to bile flow. So whenever there is obstruction to bile flow, your alkaline phosphatase level is going to increase. Okay, liver enzymes, regarding liver enzymes, we'll speak. Okay. Now, the next important thing in LFT is an albumin. Albumin, as you all know, albumin is a plasma protein and albumin is synthesized by the liver. So albumin, next one is albumin. Now the next one is globulin. Globulin again is a plasma protein, blood globulin. Those two have different functions. Albumin's function is to maintain the oncotic pressure of plasma, and globulin's function is actually to fight your infections. Globulins, we know globulins are immunoglobulins, and its function is to fight infections. And we have albumin globulin ratio. So classically, these all makes the LFT. Is it clear? Okay. So now speaking about the normal value, I don't think I can finish it in 15 minutes because one thing is that I can't move forward without explaining it completely because you need to know the concept. You never need to know by heart. You never need to by heart it like this that LFT contains liver enzymes, GOT, TPT, normal values, this and like that. I always stress on conceptual learning. Okay. So let's try to finish it at least by 9:20. Okay. So the normal value of bilirubin. Here they have given normal value, but I'll just mention the standard values. The normal value of bilirubin is between 1 to 1.5. Okay, so a value of more than 1.5, we can call it as jaundice. And this is the values according to Harrison. Okay, so values according to Harrison. Here they are given 0.3 to 1.2. I have already told you that normal value varies with different labs. According to Harrison, the value of total bilirubin is between 1 to 1.5. Okay, now speaking about the direct bilirubin, so we can have two types of bilirubinemia. We can have conjugated hyperbilirubinemia. We can have conjugated hyperbilirubinemia, or we can have unconjugated hyperbilirubinemia. We can have conjugated hyperbilirubinemia, and we can have unconjugated hyperbilirubinemia. Is that clear? So when do we call it as conjugated hyperbilirubinemia? That is important. So the value here is if the conjugated bilirubin, I will write as direct bilirubin. Okay, DB means direct bilirubin or conjugated bilirubin. If my direct bilirubin is more than 15% of total bilirubin, this value is important, guys, because many of people doesn't know this. That means when will I call it as conjugate bilirubinemia or when will I call it as unconjugate bilirubinemia? Because you know that this has got very important clinical significance because conjugated bilirubinemia we usually see in obstructive jaundice or post-hepatic jaundice because conjugation occurs in liver. We see conjugated hyperbilirubinemia in obstructive jaundice or post-hepatic jaundice. And we see unconjugated hyperbilirubinemia when there is increased production of bilirubin. When will be there increased production of bilirubin? When there is increased destruction of RBCs. Why? Because increased destruction of RBCs causes hemoglobin to release. And hemoglobin, the end product of metabolism of hemoglobin is bilirubin. And that is two, it is indirect bilirubin or it is unconjugated bilirubin. So you get unconjugated hyperbilirubinemia in hemolytic jaundice. You get unconjugated hyperbilirubinemia in hemolytic jaundice and you get conjugated hyperbilirubinemia in obstructive jaundice. So by looking into LFT, it is important for you to comment whether it is unconjugated hyperbilirubinemia or conjugated hyperbilirubinemia because unconjugated hyperbilirubinemia is due to hemolysis and conjugated hyperbilirubinemia is due to obstruction. That is extremely important. So by looking in LFT, how will we call it as conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia? So it's very simple. Just look onto the direct bilirubin. If the direct bilirubin is more than 15% of total bilirubin, If the direct bilirubin is more than 15% of the total bilirubin, we call it as conjugated hyperbilirubinemia. And vice versa. If it is direct bilirubin is less than 15% of total bilirubin, we call it as unconjugated hyperbilirubinemia. Is that clear? Okay. Now, and further workup and all. Actually, I don't think I can speak up to that now. Just complete the parameters now, because we have the jaundice is very beautiful disease, guys. Jaundice and left is actually very beautiful. We need actually, if I start speaking, we have a lot of things to speak there. But let's stick on to the basics. Okay. Now the next one is SGOT and SGPT. So these are the liver enzymes. These are called the liver enzymes, and these are stored in liver hepatocytes. Whenever there is an injury to liver, these are released into the blood cells. So normally also some amount of liver enzymes is seen in blood level, and it's usually here the lab value is correct. Usually the value of SGOT and SGPT, here they have given SGOT value between 0 to 35 and SGPT between 0 to 45. I usually remember both normal value between 0 to 45 because that's simple to remember, and a mild change in these liver enzymes doesn't make any clinical significance. That's why I usually remember the normal value of both AST and ALT between 0 to 45. I usually remember the normal value of both AST and ALT between 0 to 45. Is that clear? Okay. Now, these liver enzymes, as you guys know, these liver enzymes are elevated in certain diseases. Okay. And the most one classical elevation of liver enzymes, that means a drastic elevation of liver enzymes. Liver enzymes may go up to thousands. You might have encountered that disease at some point of your life, that is viral hepatitis. Okay, in viral hepatitis, the liver enzymes value is usually thousands. Okay, so mild elevation of liver enzymes can occur in any disease. Okay, mild elevation of liver enzymes can occur in any disease, but liver enzymes, drastic elevation of liver enzymes, instead of liver enzymes, I'll write SGOT, SGPT or AST, Okay, instead of SGOT, SGPT, I'll write AST, or liver enzyme. So a drastic elevation in liver enzyme, it is seen in mainly 3 conditions. That means more than 1000. Okay, if you're taking notes, just note this down. A drastic elevation of liver enzyme, it is seen in viral hepatitis, especially in hepatitis A. Second, it is seen in drug-induced hepatitis. If the patient is taking some drug which is severely hepatotoxic. For example, ATT. If the patient is taking anti-tubercular therapy, many of the ATTs are hepatotoxic. So if the patient is taking ATT, there can be drastic elevation in liver enzyme. For example, or otherwise, if the patient is taking methotrexate. So the examples here are ATT, methotrexate. Methotrexate is also extremely hepatotoxic drug. So if the patient is taking these drugs, the patient can have more than thousands of liver enzymes. And the third one is ischemic hepatitis. So by this time, you guys might have understood that this is my way of learning. Like for everything, I'll be having some differentials. Okay, so whenever I see these, whenever I see an elevation of liver enzyme, these are the 3 important things that comes to mind. Whenever I see thrombocytopenia, those were the 5 things important coming to my mind. In the last ECG, whenever ECG session we have discussed, whenever I see tachycardia, there are 3 things that comes to my mind. Whenever I see broad QRS, there are 4 things that comes to my mind. Whenever I see an irregular rhythm, there's 4 things that comes to my mind. Okay, so that's how I find it useful to learn because it helps you clinically better. There may be conditions which comes outside these boxes also, but these are the common things. So the next one is ischemic hepatitis. Next one is ischemic hepatitis. So in ischemic hepatitis basically means there is some problem with your heart. So your heart is not able to pump normally, and since your heart is not able to pump normally, your liver is not getting enough blood. Or it can occur in other way also, since the heart is not able to pump normally, there can be right heart failure. Since there be right heart failure, the IVCs get plethoric or IVCs get filled with blood. And since the IVCs get filled with blood, you know that IVC comes from liver. So liver gets congested. We call that Nuttenberg liver. Okay. So in ischemic hepatitis, so if there is a liver disease secondary to cardiac disease, we call it as ischemic hepatitis, and you see drastic increase in liver enzymes in these 3 conditions. You see drastic increase in liver enzymes in these 3 conditions. Is that clear? Okay. So that's about liver enzymes. Now, next one is alkaline phosphatase. So alkaline phosphatase, as I mentioned to you already, alkaline phosphatase is a marker of cholestasis. So whenever there is a cholestasis means obstruction to bile flow. Whenever there is cholestasis, that means obstruction to bile flow, your ALP value is going to rise. So ALP, speaking about ALP first point is it's a marker of cholestasis. So whenever there is obstruction to bile flow, your ALP level is going to rise. Second one is usually up to 3 times normal value of ALP, it's expected. So the normal value of ALP, you can rely this value itself. Normal value of ALP is usually 50 to 120. Actually, it is less than 150. Okay, this is something you can take. Usually, the value of ALP is less than 150. So up to 3 times rise of ALP, it can occur in any liver disease. But more than 3 times rise of ALP, more than 3 times rise of ALP is suggestive of cholestasis. So here is an important MCQ and important clinical disease that ALP is not specific for liver. Okay, ALP can also increase in diseases where the turnover of bones increase. And you all know this is an MCQ also. This is you can encounter in clinical disease also. ALP can be increased. ALP is not specific to liver, guys. It's not something specific which is present in liver. It's not specific to liver. So ALP can be increased in conditions where there is increased turnover of bones, classically seen in Paget's disease. Paget's disease is the classical example of a disease which causes increased turnover of bones. So whenever you see ALP elevation, there are 2 more than 3 times. I told you that any liver disease can cause a subtle increase in ALP levels, but more than 3 times of increase in ALP level is suggestive of cholestasis. But whenever you see an elevated ALP levels, remember that ALP can come from extra hepatic tissues also. ALP is not specific for liver. ALP can come from bone also. And classical example for elevated ALP in extra hepatic disease is Paget's disease. So how will you differentiate whether it's a liver disease or for that we do GGT, that is called gamma glutamyl transferase. Gamma glutamyl transferase is again a mark of cholestasis, but the importance is that it is specific to liver. Importance is that it is specific to liver, which means gamma glutamyl transferase will not be elevated in Paget's disease. Gamma glutamyl transferase will not be elevated in Paget's disease. So I hope the importance of cholestatic marker is pretty fine there. So ALP, we have, it is alkaline phosphatase. Alkaline phosphatase is a marker of cholestasis, and other than liver, alkaline phosphatase can also come from bone, classically in Paget's disease. But to differentiate between a bone disease and liver disease, we can go for GGT, and GGT is specific to liver. It's again a marker of cholestasis. Now, another thing, albumin, globulin, and A/G ratio. Now, I'll not be discussing a lot. Okay, I'll not be discussing about it, but just that albumin and we have globulin. Just discussing about A/G ratio here, guys. We'll be just discussing about A/G ratio here. Okay. So we know that albumin is both of them are albumin and globulin, both of them are plasma proteins. And as I have mentioned before, albumin helps to maintain your plasma oncotic pressure and globulin helps to fight infections. So usually your A/G ratio, albumin is usually always more than globulin. Usually albumin is always more than globulin. Okay, you may get certain conditions where there is A/G reversal. Also, just to mention, albumin. Okay, that's the problem here. When we start discussing, we can't contain it. But it's a basic, so I just wanted you guys to know. That means albumin's half-life. The half-life of albumin is usually around 20 days. This you don't need to remember that it is 20 days, but just know that it is not within hours. It is 20 days. That means when you have a liver disease, your albumin may be normal up to the next 20 days. Therefore, albumin cannot be used to identify a acute disease because the half-life of albumin is very high. Half-life of albumin is around 20 days. And because of that reason, you cannot use albumin as an indicator to measure an acute liver disease. So what will we use? There comes the significance of INR. You know that liver not only synthesizes albumin, liver also synthesizes certain clotting factors. Okay, liver also synthesizes certain clotting factors, and clotting factors is essential for blood clotting, and INR indirectly is a measurement of blood clotting. So when you have liver diseases, there will be decreased synthesis of clotting factors, and there will be defect in coagulation. And usually the clotting factors half-life is around 6 hours. So you can see the difference here. The half-life of albumin is around 20 days. Half-life of INR is around just 6 hours. That means you can use INR to monitor an acute disease. Albumin definitely will be decreased in chronic disease. There's no doubt in that because liver is essential for the synthesis of albumin. So albumin definitely will be decreased in chronic disease. But in acute disease, what we use is INR because INR has got much lesser half-life or clotting factors, not INR. INR is a measurement. Clotting factors has got lesser half-life, and therefore INR will be decreased in, or INR will be elevated, because clotting factors are decreased in acute diseases and INR will be elevated. I hope that point is clear. So that's very important, guys. Albumin can never be used to differentiate an acute disease, or albumin usually is normal in an acute disease because it takes at least 20 days for albumin to come down. Therefore, albumin will be reduced only in chronic diseases. What reduces or what changes in acute diseases is INR. Now, usually A by G ratio, speaking about just about A by G ratio, A by G ratio usually means there is albumin and globulin. So usually albumin value is usually more than globulin value, which naturally suggests that A by G ratio usually will be more than 1, or it's usually more than 1.1. Okay, A by G ratio is usually more than 1.1. So you have certain conditions where you get A by G reversal. You have certain conditions where you get A by G reversal. And the most important one of them is CLD. Because in CLD it's a chronic disease, and as I have mentioned, in a chronic disease, liver fails to synthesize albumin and the level of albumin goes down. There's one more reason. You have intestinal bacteria. So you all know that we have intestinal bacteria, and usually these intestinal bacteria are killed by the liver. Usually this intestinal bacteria through portal circulations from intestine reaches the liver and it is destroyed by the liver. But if your liver tissue is abnormal, if your liver tissue does not contain macrophages, it cannot destroy the bacteria. Okay, so what will liver try? Liver try to produce more antibodies. So liver tries to produce more antibodies. That means liver produces more globulin. So an abnormal liver tissue cannot destroy the bacteria. So it tries to produce more antibodies. So in CLD, you have decreased albumin, you have increased globulin, which means your A by G ratio is going to reverse. Okay, your A by G ratio is going to reverse. So one of the most important cause for A by G reversal is CLD. We have many other causes also. One more thing I'll just mention here. One is multiple myeloma. Because multiple myeloma, as you all know, is polyclonal hypergammaglobulinemia. The name itself contains hypergammaglobulinemia. That means globulin is going to increase. That means A by G is going to get reversed. You have many other things. We have something like called we call it polyclonal hypergammaglobulinemia. We have got many conditions, but understand that some important 2 points you need to understand whenever you see A by G reversal. The 2 things that should come to your mind: one is multiple myeloma. I hope it's clear. So LFT, actually we have started discussing after 9 p.m. Actually we have much and more to discuss in LFT. You have much normal values about the liver enzymes. We have much more things to discuss about LFT, but this is the basic. These all are the investigations, or these all are the parameters that we look in LFT. And I have mentioned when to call or how to call it as a conjugated hyperbilirubinemia. We call it a conjugated hyperbilirubinemia. This is extremely important, guys. We call it a conjugated hyperbilirubinemia when the direct bilirubin is more than 15% of total bilirubin. That's extremely important. Only by knowing this, you can differentiate a LFT into either a hemolytic jaundice or obstructive jaundice. Is it clear? And then we have discussed the elevation of liver enzymes. The elevation of liver enzymes very high elevation of liver enzymes. Mild elevation of liver enzymes can occur in any disease, but very high elevation, that means more than 1000, it occurs usually in 3 conditions. One is viral hepatitis, one is drug-induced hepatitis, and third one is ischemic hepatitis. Is that clear? Okay, now we have discussed about ALP. ALP is a marker of cholestasis, but it also comes from bone. So ALP is also increased in Paget's disease. So to differentiate a bone origin of cholestasis, or to differentiate whether the ALP is coming from liver or bone, we do GGT. GGT again is a marker of cholestasis, but GGT only increases in liver diseases. And then we discussed about albumin and INR. Albumin has got a much longer half-life, which means albumin will not be decreased in acute diseases. So what we measure in acute diseases is INR. Then we have discussed about A by G ratio. Okay, so A by G ratio, usually albumin is more than globulin, but in conditions like CLD, albumin values go down, globulin value goes up. Okay, so there will be A by G reversal. And in conditions like multiple myeloma, we are getting polyclonal hypergammaglobulinemia. So is that clear, guys? So we have discussed about CBC, we have discussed about renal function test, we have discussed about electrolytes, we have discussed about a liver function test. Now what this remaining is, one is ABG, then one is thyroid function test, and I have skipped certain topics. Okay, we have discussed skipped anemia plus jaundice, we have skipped isolated elevation of urea. But for the basic purpose, if you are going to start your house urgency this week or this month, this is the basic you should know. Okay, now when you get an investigation, you should not be blank. you know what all to look in an investigation. So I hope this session was useful. So guys, actually, what happens is that this is actually the final webinar. So RX Global had conducted a webinar series for you. It actually it actually contained 5 sessions, 5 different sessions by different uh, people who are acing in their specialties. So we had a radiology session, we had a emergency medicine session, we had a session on psychiatry. That means the mental issues you guys are going to face when you start internship. And we also had 2 sessions on medicine, basic medicine. One was on ECG and one is this is lab investigation. So we have totally 5 sessions, and we hope these sessions were useful for you guys. We would love to know your feedbacks. And more importantly, this is not the end, guys. It's actually just the beginning. RX Global is an initiative by a group of doctors in our college. So we are actually planning much more to help you prepare help you prepare for your further preparations, to plan your future, how to do, where to do your PGs and all. We'll be there to support you all. So please let know that I would just like to all of you to know that this is not the end, this is just the beginning. So keep in touch, guys. We are planning much more things. We'll be having more and more sessions. We'll be updating everything in group. So please be updated in the group. Okay, please be active in the group. We are planning actually a lot of things. We'll update you regarding all that in the coming sessions. So we would like to know your feedback about this webinar, because we are winding up this webinar series by today. This is the last session. We would like to know all your feedbacks. So please, just let us know how was the webinar series. Was it helpful for you guys? Have you got any difference before watching this webinar and after this? Are you confident in reading ECGs? Are you confident in reading lab investigations? Are you confident in reading X-rays? Are you confident to manage emergency scenarios? We need to know all this. So please let us know all your valuable feedbacks. We'll be there to help you. And more importantly, keep in touch, be active in the group. We are planning a lot of more things, and we'll be updating that group. So I would like to know your comments. Was this session useful, guys? This is the last session. Was it useful? As you know, I have not completed everything, but there's a limitation of time. We cannot exceed it more than 1.5 hours, because that we have promised only 1 hour, and exceeding a 1 hour session beyond 1.5 hours, it's not that good. So I would just like to know whether this session was useful for you guys. Okay, thank you very much for that. I hope it was useful for every one of you. So I hope uh, can you get recorded videos? Some of us can't join live every day. Yeah, definitely we'll try to provide you with recorded videos. We are planning to deliver you recorded videos. The recorded videos will be available. Please be in contact with us. Please be active in the group. If we have a WhatsApp group of about 400 members. So please be active in the group. Okay. We'll be giving you the recorded sessions. So we would like to know all your comments and all your valuable feedbacks in the WhatsApp group. So I would like to see that. And more importantly, as I mentioned already, this is not the end. This is RX Global is just a beginning. So we are more planning more and more sessions. So we'll be updating all those things in the group. So see you guys. Meet you in the next session. Bye, and all the best for your internship. Okay, bye.